So moving forward, we're going to be listening to Dr. Justin Taylor here from the University of Miami, talking about early detection of blood cancers. Justin Taylor is a physician scientist devoted to improving outcomes for patients with hematologic malignancies. The Taylor Lab studies the role of recurrent mutations in hematologic malignancies and how to target them with novel therapeutics using animal modeling, molecular biology, and single-cell genomic techniques. He is the principal investigator on grants sponsored by the National Cancer Institute, American Society of Hematology, the Robert Wood Johnson Foundation, and the Edward P. Evans Foundation for MDS. He has received Young Investigator Awards from ASCO Conquer Cancer Foundation, Hairy Cell Leukemia Foundation, and Evans MDS Foundation. Without further ado, Dr. Justin Taylor.
Okay, so thank you, Natasha. Thank you, Alberto. It's great to be here. This is my first time at the meeting. So from what I've heard so far, it's been fantastic. And I'm a hematologist by training. I do a lot of laboratory-based research as well, but I'm going to make this more clinically relevant and understandable to everybody. So I'll be talking about early detection of blood cancers, because basically once you come to see me with a blood cancer, we have certain treatments, but there's only so much that we have available. If we can prevent these blood cancer from happening in the first place, that would make my job a lot easier and would be better for everybody, all the patients. So I'm going to be using this word clonal hematopoiesis. I'll explain what that means, but I will also probably call it CH just for it's easier to say. Clonal hematopoiesis is a big word. This is a relatively new phenomenon, only being described 10 years ago in 2014, so we're still learning about it. Actually, with working with the Firefighter Cancer Initiative, we've been learning even more. So what is clonal hematopoiesis? This happens when a blood cell called a hematopoietic stem cell develops a certain type of genetic mutation. So this is not a mutation you're born with, but one of the cells in your body, a very important type of cell, that gives rise to all of your blood cells, develops a mutation later in life. So these blood cells have a different genetic pattern than the rest of the blood cells, and that allows them to kind of grow out of proportion to the rest of the blood cells. So this will increase over time. It will evolve into a more of a problem. But there's basically no warning signs of CH. Most people, if they have CH, they never know, because there aren't direct symptoms that would make you think of CH. The reason that we found out about it 10 years ago and how we detect it now is if people have genetic testing for some other reason. Say you are diagnosed with another type of cancer, or for some other reason you undergo a genetic test and it comes back with one of these mutations. So this is just a kind of diagram explaining that all of us have, they have to estimate how many hematopoietic stem cells you have. It's between 50,000 to 200,000, and these need to produce your blood for the rest of your life, basically. So you can have, just by chance or through exposures, develop mutations in one of these hematopoietic stem cells. If it's a mutation that's not in one of these CH genes, it may have no effect on the cells. However, if it's unlucky or for whatever reason it's selected into one of these CH mutations, like I said, that clone, we call it a clone, not thinking of Star Wars here, but that clone will expand because this mutation gives it a certain advantage over the rest of the hematopoietic stem cells. I don't know if I have a pointer here, but if you look at the far end of the graph, where it's a kind of a blue thing that gets bigger, that's the expansion of the clone. That eventually can lead to blood cancer or other cardiovascular disease and death. So this is the study that I'm referring to, 2014 study, where they were actually sequencing patients from a cardiovascular study and another study looking at diabetes and depression. So they were not expecting to find any blood cancer mutations, But if you can see from the graph on the far bottom right, as patients get older, they were detecting more of these mutations, up to about 20 to 30%. And they went back and looked at all the history. These people did not have any blood abnormalities. They did not develop blood cancer necessarily. So these were healthy people, but they're carrying, you can look at this list of the mutations. They may not mean anything to you. These are the list of genes. But if I saw these in a cancer patient, like a blood cancer patient, I would not be surprised because those are the common genes seen in blood cancer. But again, these are healthy individuals. And then what they noticed from the very beginning when this was first described was if you're in the black line, no clonal hematopoiesis, your survival was that black line. However, if you had clonal hematopoiesis in the red, the survival was less. And so the overall survival was lower, and they looked at what was that attributed to. Some of it was blood cancers, such as leukemia. But another big factor was cardiovascular disease, some solid tumors, and then other non-blood cancers. So the graph on the top right just shows if you have clonal hematopoiesis, higher risk of blood cancers. But again, it wasn't everybody that had these developing blood cancers. It was around 40% over years. And then a big thing was 40% increase in risk of cardiovascular disease, which included heart attacks, heart failure. And again, so this was just discovered. We're trying to understand what are the risk factors for developing this. One of the biggest things we know is the age. However, not a lot we can do to reverse aging. However, there are some reversible risk factors, such as smoking. That's probably the biggest one, and followed by obesity. I'll talk a little bit about germline or hereditary predisposition. And then newer things that we're finding now is sleep fragmentation, other inflammatory conditions such as listed here, arthritis, chronic infections, and then specific to the patients that I see, a lot of patients that have one type of cancer get cancer treatment, and then we detect clonal hematopoiesis actually at a higher rate after radiation or chemotherapy for, say, a non-blood cancer. So again, I mentioned age, but each year of age is only associated with a slight increase in the risk of like 0.08. So the odds ratio is 1.08, so it's a very small risk, but it does accumulate every year. And then smoking, heavy smoking is again a small risk, but still one of the most significant risks. And then this kind of Manhattan plot, they call it, is just a whole genome screening where they're looking at hereditary factors that might predispose someone to getting clonal hematopoiesis. So again, these genes may not really mean anything, but there are certain, like the TERT that you see right there in the middle. There are certain areas of the genome. If you have a hereditary gene variant there, you might be predisposed to clonal hematopoiesis. Again, not too much we know about understanding about how to prevent that or what to do about that. So we're focused more on the preventable factors and exposures. And there actually is some data about CH in firefighters from this study that was published in 2022, where they looked at the World Trade Center first responders from New York. That's in the red or the pink there. They were actually, as controls, they used from Tennessee non-World Trade Center exposed firefighters, and they documented these rates of clonal hematopoiesis. And you can see that it does increase with age as well in the firefighter population. And what they showed in this paper was that the World Trade Center exposed individuals had even higher risks of clonal hematopoiesis. And so, as you know, that led to increased incidence of leukemias, multiple myeloma, and non-Hodgkin's lymphomas in the World Trade Center responders. But, it's something maybe not so special to the World Trade Center because you also see the slightly higher risk in the control population. How does this compare to other non-firefighters that might be in similar jobs. We still don't know based on this study, but and then we know for sure, I don't have to tell this group, that firefighters are at increased risk of cancer overall. Again, 2 years ago, the IARC changed it from possibly carcinogenic to definitely carcinogenic, just the occupational exposure as a firefighter. This was based on this number of studies, a lot of case control studies and case reports, but some meta-analysis. And the types of cancers are listed here. You'll see that leukemia and MDS, the disease that I'm focused on, is not listed here, but I think with this clonal hematopoiesis that we're detecting, it could possibly be a related cancer, although there's not strong evidence for it at this time. Again, I don't have to go over the possible exposures. Those were talked about a lot here, but listed here, and the shift work, as I mentioned, that has been documented to increase risk of clonal hematopoiesis, in addition to the actual chemical exposures, and as well as UV and other forms of radiation. So to get to our specific project, this was funded through the Firefighter Cancer Initiative. Thank you to the state of Florida and to Alberto, Aaron, and then I don't think he's here, Sean Williams runs our sequencing core, as well as we use the human genomics sequencing core, Jake McCauley. So all these people helped, and the idea here was to look at the clonal hematopoiesis risk in the Florida firefighter cohort, where there are about 800 blood samples that were already stored. So again, thanks to everybody's hard work that came before me. These samples are already there. All we needed to do was extract the DNA. We have a machine that extracts DNA from 500 samples at a time, so we just randomly selected 500 samples. We extracted them through this machine. We have all the DNA stored, and now what we're doing is going through and sequencing these samples to look for clonal hematopoiesis. We've already started with 100, and the way that the plates work is you can fit 96, so it's not quite 100, but we have 96 that are sequenced, and we're doing the second 96 as we speak. And then the plan is to correlate these with cancer risks, this clonal hematopoiesis that we measure, and other outcomes, because we know it's not just cancer, it's also cardiovascular disease. And we did this, I won't go through this, this is more technical. We did a specific type of sequencing that allows you to look at very, very low levels of clonal hematopoiesis. So standard sequencing, you get a lot of this background noise on the left, and the limit of detection is 1%. With the sequencing technique we used called duplex sequencing, you can see that even down to the like 0.1%, you can detect a mutation with because you get rid of all the background noise. And this is just how it works. But the reason that we wanted to do this is because using the 1% cutoff, we know that most younger individuals, you'll not detect clonal hematopoiesis because they don't have it with a cutoff of 1 or 2%. It's typically not, it doesn't reach that level until you get over the age of 60, 70. But this Nurses' Health study, where the median age was 56, they used the same type of sequencing we used, and they were able to detect in these younger individuals clonal hematopoiesis mutations. The FCI annual cancer survey participants that we were using, this is the distribution of the ages, so you can see anywhere from 18 to 60 years old, but in generally younger people. So again, with this very, very sensitive technique, so keep that in mind, we're detecting even very, very small levels of clonal hematopoiesis, but in all 96 samples that we sequenced, we found clonal hematopoiesis in every single sample, greater than one mutation. And now there was different levels of mutations, but overall, high number of mutations. But again, this is very, very sensitive techniques. A kind of sanity check just to make sure that what we're seeing is, something that could be expected. We looked at the age of the participants, and so we ordered them from the youngest to the oldest, and some people did not want to report their age. I don't know who was not wanting to say how old they are, but you can see up until kind of where the arrow goes, the rate increases as you get older from, I think the youngest we had was 18 to 60 years old. So we do think that these mutations are real because we know that they're associated with age and they're increasing. As to, some of these are very high number of mutations, like 50 mutations in the far right. Again, with this very ultra-sensitive technique, we don't know, if all 50 of those are going to be anything clinically relevant because they're not at the 1% level yet. But this clonal hematopoiesis is there at a very low level. And so these are the types of genes that we see. And if you compare it to the list I showed you before, it's very similar to the types of mutations that have been described in non-firefighters and firefighters from World Trade Center. So we don't see that there's a vastly different type of mutations. That's another sanity check, that these are probably real. We did see that there's some DNA damage repair mutations that are enriched, which could be consistent with some sort of exposure damaging the DNA, and then these mutations are in a response to that exposure. Specifically, this RAD21 and the STAG2, there were very high levels, more than expected, and we're digging into each of those to kind of independently verify them, that we see them by other orthogonal techniques. We did see that the aging like you can look at the signature of the mutations, like ACTG, those are your DNA base pairs, and you can only have so many ways to mutate. It can go from a C to a T or a C to a G, but there's only certain combinations. And if you look at all those combinations, what we found in our firefighter cohort matched pretty well to the nurses' health study, that aging-associated mutations are the biggest risk. You can look at a different type of analysis that looks at that mutational signature by the triplet repeats of DNA. But just if you look at the colors here, the C to T is in the yellow, that's the aging. And then there's a different type of substitution type that is usually related to tobacco. It's the C to A, and that's in the blue. So again, we have the smoking history of these individuals. So I think the ones on the far right have more mutations related to tobacco exposure and less with the aging. The ones on the left have more of an aging, less of a tobacco. But we're now looking, going over the histories of the reported tobacco use and correlating that with this signature. So the conclusion of this part, and I want to also talk about what we can do about that, because I know you guys are thinking, okay, we have this clonal hematopoiesis, but what do we do about it? So let me just tell you what I just said about clonal hematopoiesis being a predisposing factor to blood cancers. However, it is rare, and most people, even if they have this CH, they're never going to get a blood cancer. Fewer than 1 out of every 100 people with CH get blood cancer every year. So 99 out of 100 people don't get blood cancer. So even though it increases your risk, it's not a definitive thing. It's also associated with high risk of cardiovascular disease, such as heart attacks. It's about the same as having diabetes. So the cardiovascular disease is actually more of a problem than the blood cancer. And then, this is very preliminary data, but it's firefighters based on the World Trade Center, and this data, they may be at a higher risk of CH, although, we need to compare this to a non-firefighter control to really see what's the increased level of risk of CH. These are what we're doing next, sequencing more samples. We plan to include non-firefighters that are age matched and maybe similar stress level of occupation. Correlate with the smoking, obesity, those other risk factors I mentioned. And you're going to hear in the next talk about heavy metals, if we can incorporate some of the that information to see if there's an exposure that we can measure related with heavy metals and CH. And then we need to get longitudinal, meaning serial samples. That would make us unique. Most of the cohorts that have been studied so far, they check one time point and then they evaluate the risk afterwards. But if people would volunteer to, have this tracked over time, that's a very unique thing that we would be able to study that many people aren't studying. So what can we do to intervene on this? So that's the big question in the field. We want to prevent blood cancers. We want to prevent cardiovascular disease. So actually at the Sylvester Cancer Center where I work, one of my colleagues has a clonal hematopoiesis clinic. Again, this is not something that it's not like your blood pressure that you can check. Not everyone's going around getting genetic testing, but if somebody happens to have a genetic test that shows clonal hematopoiesis, they can go to this clinic. Dr. Chandak is mainly following patients to see if it's evolving and treating all the cardiovascular risk prevention that we do, in people that are high risk for cardiovascular disease. Some other people on the laboratory side are looking at, in the animal models, using things like vitamin C, something that is not, that's an easy to take sort of prevention to see if that could impact it. And there's some nice preliminary studies from Dr. Cimino that shows vitamin C may, for a certain type of clonal hematopoiesis mutation, may reverse the effects of it on the epigenetics. And there's a couple of national studies for the higher risk patients with clonal hematopoiesis that have a high number of mutations or even some abnormal blood counts, but they don't yet have a blood cancer. People are testing chemoprevention drugs, these IDH inhibitors, anti-IL-1 beta antibody called canakinumab. Those are ongoing studies right now, but definitely not approved. And then there was a big study that was actually negative. They looked at low-dose aspirin in patients over 70 with CH to try to prevent the cardiovascular disease. That one, as I mentioned, was negative. It failed to prevent cardiovascular disease related to clonal hematopoiesis. However, these were over 70-year-olds. They're doing the study now for people that are younger than 70, seeing if low-dose aspirin can help prevent the cardiovascular disease related to clonal hematopoiesis. So, and then I just want to emphasize that, I already told you there's smoking, obesity, other things that we can change to try to prevent that clonal hematopoiesis. So these are people in my lab that helped do the work, and I want to again thank the Firefighter Cancer Initiative, all the participants who donated the blood. Obviously we couldn't do this study without that, and then the funding, because with this sequencing technique that we did, it is on the more expensive side, but we're hoping to make it a more cheaper thing that we can expand to more patients. So happy to take any questions. Thank you.
Hi, it was great talk. So does smoking have a unique signature, or with firefighters, is that going to be a little bit confounded by the fact that they're exposed to smoke even though they may not use tobacco?
Yeah, that's a great question. So there is this known smoking signature, but we don't know if you're exposed to other types of smoke that's not from cigarettes, whether it gives the same signature or not. I don't think, maybe somebody else knows, but at least I don't know of a specific signature for those types of. There are other signatures for UV. Chemotherapies can cause certain signatures, but I don't know of any signatures for the smoke from a fire. Yeah.
Hey, Dr. Taylor, Lana McKee. So 2 quick questions. So these CH mutations, are they captured on like your traditional comprehensive genomic profiling tests, or is this some special subset that you guys look for?
Yeah, thank you for the question. I didn't get into the details of our panel, but we're using a 60 gene panel, and we're sequencing very, very deep. If you were to get like a kind of whole genome, whole sort of screen, those are often done at a not very deep sequencing. So they would probably miss these because they're very low level mutations. So, but if the panel included these 60 genes, it's possible they might be, and if it's, especially if it's a kind of like a cancer panel that we might run that does do deep sequencing.
So,
Did that
and
answer the
I'm-
question? But
Well,
yeah, like,
so that's first, and the second one, so assuming that it's a 60-gene panel, do you guys do an in-house panel? Is that an in-house developed panel, or is it one of the commercial? Like, is it your Foundation or Caris or Tempus test, or is it something that you guys use specifically?
a great question again. Yeah, this one was our own panel that we built. I mean, with a company, but we designed it. That's great that you bring up Foundation, Tempus, and Caris, because those are kind of cancer panels. Those would be on those panels as well.
Thank you for that. Good presentation.
Okay. Thanks.
Thank